Good evening, doctors. Tonight, I will be presenting the topic of BPH, or benign prostatic hyperplasia. So, BPH, or benign prostatic hyperplasia, is a pathologic process that is one, but certainly not the only cause of lower urinary tract symptoms, or LUTS, in aging men. Also, it is also described as male LUTS. Prior, it was termed as prostatism, but it was noted to be erroneous. So, ginawa ng male LUTS. So, for the etiology, it is important to note that in BPH, there's an increase in number of epithelial and stromal cells in the periurethral area of the prostate. The observed increase in cell number may be caused by epithelial and stromal proliferation or impaired programmed cell death, leading to cellular accumulation. So hindi lang siya hyperplasia, hindi lang siya production, meron ding impaired programmed cell death or impaired apoptosis. So although androgens and growth factors were noted to stimulate cell proliferation in experimental models, the relative role of cell proliferation in human BPH is questioned because there is no evidence of an active proliferative process. No, so androgens are not only are required for normal cell proliferation, but also actively inhibit cell death. So the same is also the case for estrogen or estradiol. They were also noted to inhibit cell death. And also androgen withdrawal leads to the activation of specific genes involved in programmed cell death. So when the proliferating cells mature through a process of terminal differentiation, they have a finite lifespan before undergoing programmed cell death. In the BPH paradigm, it is noted that the aging process induces a block in this maturation process so that the progression to terminally differentiated cells is reduced, thereby reducing the overall rate of cell death. So although androgens do not directly cause BPH, the development of BPH requires the presence of testicular androgens during prostate development, puberty, and aging. Assuming normal ranges, there is no clear relationship between the concentration of circulating androgens and prostate size in aging men. So the presence of the testicular androgens, yung existence yung action ng testosterone and DHT sa prostate is mediated indirectly through autocrine and paracrine pathways. So in the prostate, the nuclear membrane-bound enzyme steroid 5-alpha reductase converts the hormone testosterone into DHT, the heterotestosterone, comprising around 90% in the prostate, which is also the principal androgen in the tissue. The prostate, unlike other androgen-dependent organs, maintains its ability to respond to androgens throughout life, unlike kunyari sa penis na epithelium. Kapag hindi namatay yung androgen receptors dun, if it stays there throughout life, so parang haba lang ng haba yung penis mo. So androgen receptor levels in the prostate remain high throughout aging. So in the figure, you can see that may stromal cells and epithelial cells. So you can see that the 5-alpha reductase type 2 is mainly found in the stromal cells. So type 1 5-alpha reductase, which is the predominant enzyme in extraprostatic tissues such as the skin and liver, is normally expressed in the 5-alpha reductase deficiency syndrome and is inhibited by dutasteride, but not by finasteride. Kasi yung finasteride is selective sa type 2 5-alpha reductase, while dutasteride is non-selective. Yung type 2 5-alpha reductase is the predominant prostatic 5-alpha reductase, particularly in the stroma, prostatic stroma, although it is also expressed in extraprostatic tissues. So, meron din tayong tinatawag na stromal-epithelial interactions in which prostatic stromal and epithelial cells maintain a sophisticated, quote-unquote, paracrine type of communication there is research that provides strong evidence that one class of stromal cell excretory protein partially regulates the epithelial cell differentiation. So inisip nila maybe BPH can be caused by a defect in that stromal component that normally inhibits cell proliferation, resulting in the loss of a normal braking mechanism for the proliferation. Kaya ka nag-BPH. So growth factors were also noted to contribute to BPH. Interactions between growth factors and steroid hormones may alter the balance of cell proliferation versus cell death to produce BPH. So yung fibroblast growth factor 1, 2, 3, and 7, or the keratinocyte growth factor, and the TGF beta and epidermal growth factor have been implicated in prostate growth. And naka-bold yung keratinocyte growth factor in sa research nila is it is known to be the leading candidate for the factor mediating the stromal cell-based hormonal regulation of the prostatic epithelium. So, meron din tayong genetic and familial factors in BPH. They have substantial evidence that BPH has an inheritable genetic component. Particularly, mina-isolate sila sa 2q31 and 5p15. And it is consistent with an autosomal dominant inheritance pattern, if ever meron. Kasi may sporadic din. So, familial BPH was characterized by large prostate size with a mean prostate volume of 82.7 ml in men with hereditary BPH compared dun sa 55.5 ml in men with sporadic BPH. So the pathophysiology of BPH is complex. Prostatic hyperplasia increases the urethral resistance, resulting in compensatory changes in the bladder function. However, the elevated detrusor pressure required to maintain the urinary flow in the presence of increased outflow resistance occurs at the expense of normal bladder storage function. So obstruction-induced changes in the detrusor function, compounded by age-related changes in both bladder and nervous system function, can lead to urinary frequency, urgency, and nocturia, which is the most bothersome BPH-related complaints. So the BPH first develops in the periurethral transition zone of the prostate, as provided by McNeil in last 1978. A transition zone consists of two separate glands immediately external to the pre-prostatic sphincter. The main ducts of the transition zone arises on the lateral aspects of the urethral wall at the point of urethral angulation near the verumontanum. Proximal to the origin of the transition zone ducts are the glands of the periurethral zone that are confined within the pre-prostatic sphincter and course parallel to the axis of the urethra. All BPH nodules were noted to develop either in the transition zone or in the periurethral zone. Although early transition zone nodules appear to occur early within or immediately adjacent to the pre-prostatic sphincter, as the disease progresses and the number of small nodules increase, they can be found in almost any portion of the transition of the periurethral zone. So the transition zone, it is important to note that the transition zone enlarges with age unrelated to the development of nodules. So in BPH, dumadami yung stroma sa transition zone and also dumadami din yung nodules. So, ayun, this is just a figure to show the area of the transition zone and where its duct is supposed to come out near the verumontanum. So one of the unique features of the human prostate is the presence of the prostatic capsule, which plays an LUTS in humans. So in the dog, which is the only other species known to develop naturally occurring BPH, symptoms of bladder outlet obstruction and urinary symptoms rarely develop because the canine prostate lacks a capsule. So presumably, the capsule transmits the pressure of the tissue expansion to the urethra and leads to an increase in urethral resistance. So masasabi natin natin na clinically significant yung prostatic capsule since the incision of the prostatic capsule through TUIP results in a significant improvement in outflow obstruction, despite the fact that the volume of the prostate remains the same. So for the histologic features, majority of early periurethral nodules are purely stromal in character. So these small stromal nodules resemble embryonic mesenchyme with an abundance of pale ground substance and minimal collagen. So the earliest transition zone nodules represent proliferation of glandular tissue. These glandular nodules are apparently derived from newly formed small duct branches of the prostate. So ayun, the bladder's response to obstruction. It is important to note that changes that lead to detrusor instability or decreased compliance are clinically associated with increase of frequency and urgency. And that changes associated with decreased detrusor contractility are associated with further deterioration in the force of the urinary stream, hesitancy, intermittency, and increased residual urine. So yun yung bladder decompensation na. The major endoscopic detrusor change, trabeculation, is caused by an increase in detrusor collagen. The initial response of the detrusor to obstruction is the development of smooth muscle hypertrophy. It is likely that this increase in mass, although an adaptive response to increased intravesical pressure and maintained flow, is associated with cellular and extracellular changes in the smooth muscle cell that leads to detrusor instability and in some cases impaired contractility. So next we go to the evaluation and the non-surgical management of BPH. So LUTS are considered as a clinical manifestation with a multifactorial pathophysiology that can arise from different conditions. So ayan yung different conditions. So it is clear that patients bothered by LUTS are seeking first medical help, and seeking first medical help cannot be regarded as affected only by bladder outlet obstruction caused by BPH until a more comprehensive assessment of their condition has been undertaken. So the proper diagnostic assessment of men complaining of LUTS represent a major issue in the everyday clinical practice of both GPs and urologists. So, syempre, a basic diagnostic evaluation would include a medical history, physical exam, and urinalysis. These are often used in evaluating patients with LUTS since first mag-rule out ka muna ng non-prostatic causes. So additional diagnostic tests could be further required to better clarify the diagnosis, improve disease severity, estimation, and predict the response to treatment. So the main goal of the baseline interview of any patient is to identify potential causes of LUTS as to further address the diagnostic and therapeutic decision-making process with a more patient-tailored approach. So, merong medical conditions na can present as LUTS, no, including diabetes, renal diseases, heart failure, sleep apnea, neurologic diseases, a history of conditions affecting the lower urinary tract, and the occurrence of gross hematuria should be investigated as well, along with the history of any previous surgical intervention involving the prostate, bladder, or urethra. So medications that may significantly impair bladder contractility should also be asked from the patient, like intake of loop diuretics, beta blockers, anticholinergics. So for the symptom assessment, the IPSS is currently considered the international standard tool to investigate LUTS severity. So recently, mayroon tayong further segregation ng IPSS into storage and voiding subscales. But these subscales, nag-suggest sila na these subscales can provide a more reliable measure of storage and voiding functions. So, bale yun yung FUN, tas yung WISE. So, the quantification of symptom severity and the assessment of how a given level of symptoms may affect each man's quality of life provides valuable information in terms of the severity of disease, response to therapy, and also the risk for disease progression. So, yung IPSS, may 7 questions, yung fun-wise, and also yung last question, which is the quality of life, tinatanong din. So, may grading tayo dyan as mild, moderate, and severe. So, pag 1 to 7, mild, pag 8 to 19, moderate, and pag 20 to 35, severe. So next is the physical examination. So physicians should accurately assess the male pelvis, mostly to identify disorders potentially associated with lower urinary tract symptoms. So the suprapubic area must be inspected to exclude an overdistended, palpable, or percussible bladder. So the penis should also be examined to exclude any stricture of the external meatus, potentially responsible for bladder outlet obstruction, as well as the presence of a phimosis or of malignant lesions of the penile skin or the foreskin. The ventral side of the penis should also be palpated to search for palpable urethral masses that can present as an indirect sign of discharges, can also be a sign of urethritis, and the testicular size, along with other secondary male sex characteristics, can be indicative of a metabolic syndrome. And metabolic syndrome can be associated with BPH, positively correlated. So the DRE is done for 2 reasons. One, to obtain a baseline estimation of the prostate volume, which is a useful parameter throughout the clinical decision-making process, and also to exclude the presence of palpable nodules or any increased consistency that may signal the presence of prostate CA. So it is important to note, however, that the direct rectal examination, digital rectal examination, its sensitivity is low in prostate CA. And the prostate volume usually is to be underestimated by the DRE because of the impalpable areas on the bilateral prostate, especially bilateral lobes of the prostate, especially for prostate volumes greater than 30 ml. Finally, the anal sphincter tone should be assessed while a DRE is being performed, since a flaccid or spastic sphincter may be a sign of neurologic disorders. So frequency volume charts, they are generally, the international clinical guidelines advise that FDCs should be used during the basic evaluation of patients with prevalent storage LUTS or nocturia. And according sa research nila, at least 3 days or more dapat ginagamit yung frequency volume charts. Urinalysis, the use of a dipstick test and or the microscopic evaluation of urine samples is suggested in all patients complaining of LUTS as part of a baseline evaluation. Urine cytology should always be requested in men with severe storage symptoms and dysuria, especially if they have a smoking history, since mag-entertain ka na ng possibility of malignancy. So, the value of PSA testing among patients presenting for LUTS is multiple. So they can assess risk and eventually rule out the presence of prostate CA, although screening tool lang siya. And it can estimate prostate volume daw according to studies. Since may study na yung PSA level na more than 1.6 nanogram per ml for patients in their 50s and more than 2.0 for patients in their 60s, tapos 2.3 sa patients na 70 years old and above, was associated with a sensitivity of 70% and a specificity of 65 to 70% in terms of detection of prostate volume greater than 40 ml. So it can also um, predict BPH-related outcomes in that it predicted changes in terms of lower urinary tract symptoms, symptom severity, quality of life, and maximum urinary flow rates. Moreover, baseline PSA levels was found to be a consistent predictor of acute urinary retention and BPH-related surgery in the placebo arm of large long-term randomized controlled studies. So current international clinical guidelines suggest the measurement of PSA. If a diagnosis of PCA or prostate CA will change LUTS management. So usually ang sinasuggest nila, if may life expectancy ka pa of more than 10 years, you actually request for PSA since pag na-diagnose mo siya, mag-iiba nga yung management. So next is renal function assessment. So it is not routinely suggested according to clinical guidelines. Pero yung European guidelines suggest assessment of serum creatinine level if on the basis of medical history or when surgical treatment is being considered. So in clinical practice, post-void residual of less than 30 ml is usually considered non-significant, whereas PVR volume persistently greater than 50 could be regarded as important. Currently, there is no standardized definition for a normal post-void residual. The large within subject variability in the PVR volume assessment is noted since wide volume variation was reported in 66% of cases when three measurements were done on the same day. So magkakaiba yung post-void residual volumes nila on the same patient. So in 2014, the ICS Urodynamics Committee established a guideline for the correct assessment of post-void residual volume. So first, the interval between voiding and PVR volume measurement should be of short duration. Although hindi sinabi kung gaano ka short dapat yung duration. Although transurethral catheterization is considered the gold standard to assess post-void residual volume, it could be associated with patient discomfort and there is the risk for UTIs and urinary tract trauma. So hindi siya ginagawa. So the ultrasound bladder volume measurement should be used to assess PVR volume and can be performed with either a portable bladder scanner. So it is important to note that in the PVR volume studies, its presence is not highly correlated with bladder outlet obstruction. So PVR volume of 200 to 300 ml may indicate netruce or underactivity and predict a less favorable response to LUTS treatment. So PVR volume does not correlate with the need for BPH-related surgery, and the association with PVR volume with acute urinary retention has not been established. Next, Uroflowmetry is a basic non-invasive urodynamic test providing an objective and quantitative indication of the integration of bladder function and outlet. So main parameters provided by Uroflowmetry are yung Qmax or yung peak flow rate, voided volume, and flow pattern. So the average flow rate is considered less accurate than the peak flow rate to detect bladder outlet obstruction. So there is substantial within subject variation in terms of Uroflowmetry results among measurements taken either on the same day or on consecutive days. Kaya limited siya. So Qmax is greatly influenced by the voided volume. Flow rate measurements are usually inaccurate if the voided volume is less than 125 to 150 ml. And there is evidence of possible changes in the Uroflow parameters associated with different voiding positions to undergo Uroflowmetry in their own preferred position. So according to expert opinion, a PFR cutoff of 15 ml per second could be used to define outlet obstruction in clinical practice. However, a PFR of less than 15 ml per second does not differentiate between obstruction and bladder decompensation. So international guidelines consider uroflowmetry as an optional test in the assessment of patients with LUTS, although its use is recommended before any active treatment is done. So next is urodynamics. So invasive naman to. It is the gold standard for the assessment of lower urinary tract symptom pathophysiology, and it is used to identify the detrusor overactivity, underactivity, low bladder compliance, and bladder outlet obstruction. So may two distinct evaluations investigating the storage and voiding phase of micturition. So one is the filling cystometry, and the other is the pressure flow study. So urodynamic testing involves the use of catheters or transducers inserted into the bladder and or other body cavities. So sa filling cystometry, you allow the assessment of the storage phase. So patients are instructed before the test on how to report sensations. You ask pag meron ng first sensation of filling, first desire to void, and then the strong desire to void. So in patients with LUTS suggestive of bladder outlet obstruction, the main goal of the test is the detection of involuntary detrusor contractions, which may identify detrusor overactivity. So next is the pressure flow study, or PFS, and it allows the assessment of the voiding phase. It is defined as the measurement of the intravesical and abdominal pressure, while uroflowmetry is performed with a transurethral catheter in place. So the joint evaluation of the detrusor pressure and flow rate allows a diagnosis of either bladder outlet obstruction, which is characterized by impaired flow rate along with an increased detrusor pressure, or detrusor underactivity, which is characterized by the impairment of both the flow rate and the detrusor pressure. So the detrusor contractility is not influenced by active treatment and duration of the bladder outlet obstruction. So although not routinely advised, PFS is suggested before invasive treatments in some specific scenarios. So in the following, so patients with previously unsuccessful invasive treatments for LUTS, patients who cannot void more than 150 ml, patients with PVR volume that is greater than 300 ml, and patients older than 80 and younger than 50 of age with predominantly voiding LUTS. So in terms of upper tract imaging, routine assessment of the upper tract with ultrasonography is not recommended in patients with LUTS. Imaging is only done when LUTS is combined with elevated serum creatinine level or large PVR volumes, or if the patient has a history of hematuria, UTI, urolithiasis, or prior urinary surgery. So naghahanap na ng ibang cause. So in terms of prostate and bladder imaging, transrectal ultrasonography imaging is considered the method of choice to define prostate volume, which can be a valuable in serving as a predictor of treatment outcomes. So candidates for treatment with 5 alpha reductase inhibitor should be evaluated for prostate volume prior to treatment. Gagawin siyang baseline gland volume kasi 5 alpha reductase inhibitors are noted to decrease prostate volume. So ultrasound-based estimation of prostate volume, either suprapubic or transrectal, should be routinely performed before any BPH surgery. So meron tayong tinatawag na intravesical prostatic protrusion, or the IPP. It is defined as the distance from the tip of the protruding prostate to the base at the circumference of the bladder, and can be assessed by suprapubic ultrasound imaging in the sagittal plane. So it showed good overall accuracy in predicting the outcome of a trial without catheter after an episode of acute urinary retention. But given the wide variability in the threshold values used and in terms of the method of assessment, there's currently no clear recommendation for using IPP as a non-invasive alternative to pressure flow studies to diagnose outlet obstruction. So other imaging workups, so may cystourethrogram, you can suggest it as an additional diagnostic test when urethral strictures or bladder abnormalities are suspected. And also cystourethroskopy, which can provide information regarding the morphology of the prostate and bladder neck and the detection of the true sore trabeculation at the level of the bladder wall or the presence of diverticula. But it can neither useful for the diagnosis of bladder outlet obstruction nor determine the need for treatment. It is suggested in cases of reported gross hematuria, history of bladder CA, history of recurrent UTIs, or urethral injury, or in the case of previous surgery, the prostate or urethra. So, ayan, meron tayong algorithm. No? So, assessing symptom severity is the first step in the workup of patients with LUTS through comprehensive history taking and PE with DRE and different methods of evaluation as indicated per patient. So, the PSA test should be considered for patients with a life expectancy longer than 10 years. Ultrasound imaging and uroflowmetry should be performed for patients with moderate to severe symptoms. And invasive urodynamic tests should be considered if bladder motility alterations are suspected. So both the American and European guidelines, expert consensus panel suggest that patients with mild to moderate non-complicated LUTS who are minimally bothered by their symptoms should be offered conservative management. So, ayan. So usually, you assess first if the symptoms are noted to be bothersome. So kung hindi, usually we opt for watchful waiting. Siyempre kasama na yung education doon and lifestyle modifications. So watchful waiting is based on reassurance and education of the patient, lifestyle interventions, and periodic monitoring of the disease. So the rationale behind watchful waiting is based on the evidence that a number of patients with LUTS suggestive of BPH are affected by an indolent non-progressive disease that does not require active treatment. So data from longitudinal community-based studies showed that unfavorable outcomes such as acute urinary retention and BPH-related surgery are relatively uncommon throughout the natural history of BPH patients, with a cumulative incidence of 1% for AU, 1 to 2.7% for AUR, and 3% for surgery. So it is important to note, however, that if patients choose watchful waiting as a preferred management, they should be followed up yearly to detect any progression in terms of symptoms. Since yung natural history ng disease, lalo na pag watchful waiting sa BPH, usually nagpo-progress sila. May studies na dictate din na 24% waiting and those with higher baseline bother score showed a higher risk for crossing over to surgery. So sa lifestyle and dietary modifications, important yung mga aspects na yan. So for education and reassurance, you discuss the causes of LUTS, including the natural history, normal prostate and bladder function. And for the fluid management, you advise usually 1.5 to 2 liters with daily. And you avoid caffeine and alcohol, especially in the evening if nocturia is bothersome. So you usually also adjust time when medications with an effect on the urinary system is taken to reduce LUTS at the times of greatest inconvenience. And lastly, you can train the patient to double void, to do urethral milking, or you do bladder retraining. So medical therapy plays a major role in the management of patients with LUTS. So until the 1990s, usually surgical treatment was the mainstay of treatment for patients with BPH-related LUTS until the so the first medical therapy is considered the first line treatment for patients bothered by LUTS without imperative indications for surgery. So the drug therapy should be tailored to the patient's symptoms, and the physician should always discuss with the patient the benefits and risks of all available drugs before deciding on any specific treatment. So may goals tayo na sa LUTS medical treatment. No, so this includes relieving symptoms, decreasing VOO, improving bladder emptying, ameliorating the true overactivity, reversing renal insufficiency, and preventing the disease progression. So meron tayong outcome measures in terms of sa medical therapy natin. So you assess the symptoms, you assess bladder outlet obstruction. Usually ginagamit natin is Uroflowmetry over pressure flow studies, and bladder emptying using the Postvoid residual volume. And you can also assess the true overactivity. So yung isa sa meds na tinitake for LUTS or for BPH is alpha-adrenergic blockers. So the alpha-1 adrenergic receptor subfamily plays a major role in the pathophysiology of LUTS and is the target of alpha-1 blockers. So of the alpha-1 adrenergic receptor population, the alpha-1A subtype accounts for 70% within the prostate. And Moriyama analyzed the expression of alpha-1 adrenergic receptor messenger RNA in BPH and non-BPH prostate tissues. So they found out that yung alpha-1A is present, yung nag-account pala siya for 85%, and yung alpha-1B is 14%, and yung alpha-1D is just 1% of the total expression in BPH prostate tissues, compared with 63%, 6%, and 31% in non-BPH prostate tissues respectively. So, makikita nyo dyan yung mga dots along the bladder and the prostate, and makikita nyo sa urethra din. And yung blue is the alpha-1A adrenergic receptor. Nakikita natin yun nga, pinakamarami yung alpha-1A. And the blockade of alpha-1 adrenergic receptors leads to the relaxation of smooth muscle tissue at both sites, with a decrease of the sympathetic baseline muscle tone and a consequent relief of symptoms. However, the effect of alpha-1 blockers on bladder detrusor function has not yet been clarified. So these are the drugs, in classification ng alpha-adrenergic blockers natin with the recommended doses. So first, yung non-selective phenoxybenzamine. It showed a significant improvement in uroflowmetry parameters and significant relief sa symptoms. However, due to the non-selectivity of the molecule, blocking both alpha-1 and alpha-2 receptor subtypes, nagkakaroon tayo ng serious cardiovascular adverse effects. And ever since, the drug was no longer used to treat LUTS or BPH. So they went to the selective alpha-1 blockers naman. So prazosin was the first selective alpha-1 adrenergic receptor antagonist investigated for LUTS treatment. It is better tolerated than phenoxybenzamine. Prazosin, however, has a short serum elimination half-life. It was then replaced by terazosin and doxazosin, which have longer half-life, so mas convenient yung dosing niya. So both drugs were associated with significant treatment emergent adverse effects caused by smooth muscle relaxation at the vascular level. So nagkakaroon pa rin ng symptoms, pero usually tolerated na. So sa terazosin, Studies revealed a 22.4% reduction in symptom scores, with significant increase in peak flow rates and mean urinary flow rates. But it is noted that the effects were dose dependent, and yun nga, better results with the 10 milligram tablet. So overall, the adverse effects were minor and reversible in terazosin treated groups. So pinakamalala was dizziness at 26% and asthenia or generalized weakness at 14%. Of note, 19.7% of patients discontinued the use of terazosin because of adverse effects. So terazosin was noted to induce epithelial and stromal apoptosis sa isang study. However, terazosin was not shown to reduce prostate volume when compared with placebo. So dose titration is recommended to minimize the risk for first dose hypotension and syncope. Patients should be counseled to start treatment with 1 milligram terazosin taken at bedtime when further titrating it. So next is the doxazosin. Symptom scores were noted to decrease significantly by 39% in the treatment group versus 17% sa placebo. So peak flow rates increased by 2.9 ml per second versus 0.7. However, the standing and sitting blood pressure were noted to significantly decrease for the 4, 8, and 12 milligram doxazosin groups compared with placebo. So sa MTOPS trial, doxazosin alone reduced the risk for clinical progression of BPH by 39% as compared with placebo. So overall incidences were, of dizziness was 11%, asthenia 6%, and postural hypotension 2% with doxazosin. So meron sa doxazosin, meron silang dinevelop na gastrointestinal therapeutic system, sustained release formulation. It was supposed to, the goal was to enhance the pharmacologic profile of the drug in that lower yung maximum plasma concentration niya and yung minimum therapeutic concentration was sustained for a longer period. So there's the earlier onset of symptom relief and increase in the flow rates compared with the standard formulation. Doxazosin was also noted to be associated with cell apoptosis due to its quinazoline structure, and it stimulated the production of TGF beta 1. So TGF beta 1 is noted to regulate the programmed cell death. Noted significant changes in prostate volume, even after treatment with doxazosin compared with placebo. Next is alfuzosin, uroselective alpha-1 blocker. There is high selectivity over vascular tissue with alfuzosin, and there's also poor diffusion in the CNS. So this pharmacokinetic profile is reflected in a high efficacy for relieving LUTS along with a lower rate of cardiovascular adverse effects or CNS adverse effects. With alfuzosin, again, there's no first day effect on blood pressure with the 10 milligram dosing in both normotensive and hypertensive patients. Hence, the 10 milligrams once daily dosing is effective and a safe compound with no need for dose titration. Alfuzosin pala, hindi siya selective sa kahit anong subtypes ng alpha-1 receptors. Pero uroselective siya in a sense na mas gumagana siya sa So next is tamsulosin. It is a uroselective alpha-1 blocker with high affinity for alpha-1A and 1D receptor subtypes. So administration of tamsulosin led to a dose-dependent increase expression of alpha-1A and alpha-1D receptors in prostatic tissue. So with tamsulosin, peak flow rates increased within 4 to 8 hours after a single 0.4 milligram dose, and symptom relief was evident after 1 week of treatment. So the adverse effect incidence was comparable after treatment with the 0.4 milligram dose and placebo, but greater sa 8 milligram dose. So, and also symptomatic relief was slightly greater with 0.8 milligrams tamsulosin compared with 0.4 milligrams. However, notwithstanding that tamsulosin was generally well tolerated and that rates of adverse effects and treatment withdrawal were dose dependent. Hence, yung 0.4 milligrams yung naging formulation of choice for LUTS treatment. Next is silodosin. Uroselective alpha-1 blocker din siya. Ito naman yung may highest selectivity for the alpha-1A adrenergic receptor subtype. So it has a 583-fold and 56-fold higher binding affinities compared with the alpha-1B and 1B subtypes. So the most common reported adverse effect is anejaculation. However, nakikita yung anejaculation in around 26% of patients taking silodosin. But it is notable that 2.8%, only 2.8% of patients discontinue due to the symptom. Silodosin is recommended at a daily dose of 8 milligrams taken with a meal. Next, only compound developed with a distinct selectivity for the alpha-1B adrenergic receptor subtype, in that it is threefold higher than the alpha-1A subtype. It is found to be non-inferior to low-dose tamsulosin. Silodosin, however, was noted to be superior in terms of IPSS reduction and quality of life improvement without differences in the Uroflowmetry parameters. So, among non-uroselective alpha-1 blockers, yung terazosin and doxazosin have both shown a good efficacy profile in terms of both symptom relief and uroflowmetry parameter improvement. Both drugs would need dose titration to avoid the risk of vascular-related adverse effects associated with first dosing. And the doxazosin therapy, the GIT formulation, was noted to result in a greater reduction in total IPSS than tamsulosin, but there were no differences observed in terms of peak flow rates after treatment. So both tamsulosin and alfuzosin are uroselective compounds that do not require dose titration and are currently recommended for use at the daily dose of 0.4 milligrams and 10 milligrams respectively. So for the safety profile of alpha-1 blockers, treatment emergent adverse effects associated with alpha-1 blockers are caused by the effect of every drug on the vascular tissue, the CNS, and the urogenital system. So overall, dizziness, asthenia, hypotension, and anejaculation are the most commonly reported as adverse effects according to RCTs. And pinaka-common nga again sa silodosin is yung anejaculation. The hemodynamic side effects of alpha blockers is due to the high affinity of non-uroselective compounds for the alpha-1B subtype, which is widely present at the level of vascular tissues, inhibition of which leads to hypotension, dizziness, syncope, etc. So among uroselective compounds, alfuzosin was noted to show a slightly greater impact on the cardiovascular system compared with tamsulosin. And 8 milligram silodosin is not associated with a significantly higher risk for hypertension or other vascular adverse effects compared with placebo. So for the special populations, in patients with cardiovascular diseases, alpha-1 blockers should be carefully administered in patients taking antihypertensive meds. Hindi recommended na mag-take ng alpha-1 blockers with other alpha blocking compounds. And for the elderly patients, the adverse effects such as dizziness and orthostatic hypotension may very well lead to falls, fractures, and institutionalization. So physicians should be more cautious with elderly patients regarding the risk of first dose hypotension with alpha-1 blockers. So in terms of sexual function naman, positive effects of alpha-1 blockers on erectile function have been variably observed and ascribed to the beneficial effect of these drugs in terms of LUTS relief and quality of life improvement. Alpha adrenergic receptor inhibition within cavernosal tissue may lead to smooth muscle relaxation and to a consequent enhancement. So ejaculation disorders was significantly higher for silodocin than for tamsulosin. So next we go to androgen manipulation. So as previously mentioned, prostate tissue is androgen dependent, and both testosterone and DHT play a key role in the development of BPH. So again, type 2 isoenzyme is mainly expressed at the level of the prostate, particularly in the stroma and genital tissues. So initially, castration and pharmacologic agents suppressing testosterone and DHT synthesis or action are able to reduce prostate volume in men with BPH. But however, yung limitation nito is that the LUTS pathophysiology is not entirely dependent on prostate size. So ito yung list ng drugs na ginamit. Pero yung the use of progestational anti-androgens induce the prostate atrophy by suppressing steroid synthesis at the level of the testis without suppressing the luteinizing hormone. And flutamide and bicalutamide blocks the binding of the testosterone and DHT to the androgen receptor. However, all of these compounds were associated, including the gonadotropin releasing hormones. They were associated with adverse events related to the alteration of the hypothalamic pituitary gonadal axis or the HPG axis, which is undesirable. Hence, they went down sa cascade and doon nila na-discover yung 5-alpha reductase inhibitors. It blocks the conversion of testosterone to dihydrotestosterone in prostatic stroma cells by inhibiting the enzyme 5-alpha reductase without a significant interaction with the HPG axis. So the 5-alpha reductase inhibitors, finasteride and dutasteride, currently represent the paradigm for androgen suppression in the treatment of BPH. It is important to note that the outcomes of clinical trials with 5-alpha reductase inhibitors should be considered reliable only for time points at or after 6 months from the beginning of treatment. So finasteride is a selective inhibitor of the type 2 5-alpha reductase isoenzyme. It decreases intraprostatic DHT levels without reaching a castration level due to the remaining activity of the type 1 isoenzyme, converting testosterone to DHT at the level of the skin and the liver. After 12 months of treatment, the mean reduction in prostate volume from the baseline was 19% in men treated with 5 milligrams of finasteride. So the drug was noted to be overall well tolerated. The most adverse events were decreased libido and ejaculatory disorders. So in terms of disease progression, fewer patients in the finasteride group as compared with the placebo group developed urinary retention or needed prostate surgery. So it went along with a 52% reduction in PSA volume, PSA value dun sa studies. It is demonstrated to significantly decrease serum PSA levels by approximately 50%. In terms of PCA detection, prostate CA detection, results from prostate cancer prevention therapy trial demonstrated that treatment with finasteride significantly increases the sensitivity of the PSA test in predicting prostate CA. So in an RCT, gross refractory hematuria recurred within 1 year in 63% of men randomized to receive placebo, and in 14% of men randomized to receive finasteride. So baka may role yung finasteride in preventing gross hematuria. So dutasteride naman is a dual inhibitor of the 5-alpha reductase types 1 and 2. So there is a greater decrease of serum dihydrotestosterone levels compared with finasteride. So the most frequent adverse events were erectile dysfunction and decreased libido. However, these rates was noted to significantly drop after 2 years of treatment. So baka may tolerance. So it is recommended at a daily dose of 0.5 milligrams with or without a meal. Long-term treatment, again, is usually needed to observe a clinical benefit, at least 6 months. In terms of symptom relief and peak flow rates increase between patients treated with dutasteride and patients treated with finasteride. So medyo equal yung effectivity nila. It is noted that there was a 23% relative reduction in the risk for prostate CA within 4 years of treatment with dutasteride. So finasteride was also noted to reduce the incidence of prostate CA according to Prostate Cancer Prevention Trial, PCPT. A common trend with 5-alpha reductase inhibitors is that the incidence of PCA is reduced but is diagnosed usually at a higher stage when detected. So tulad nito, a small increase in the number of cancers with Gleason score of 8 or more was observed in the treatment arm. As with finasteride, there is the 50% reduction in PSA level with the dutasteride treatment. So other medications, aromatase inhibitors like atamestane is a highly selective aromatase inhibitor that lowers both serum and intraprostatic levels of estradiol and estrone. However, there was a symptom or improvement of urinary flow parameters. Moreover, an increase in peripheral androgen concentration was observed, and yun maybe yung cause ng lack of efficacy ng drug. So for the safety of androgen manipulation therapy for BPH, there was said to be an association of 5 ARIs on non-alcoholic fatty mellitus, but hindi siya confirmed in any available clinical studies. And androgens were noted to have an important role in the metabolism of bone and muscle. So hence treatment with 5 ARIs which affects the serum levels of dihydrotestosterone may have an influence on these 2 levels. However, the bone mineral densities of patients receiving finasteride and dutasteride for 4 years was not significantly different as from that of patients receiving placebo. So the use of 5-alpha reductase inhibitors was not associated with an increased risk of suicide, but there was a significantly higher risk for depression. So patients should be properly counseled regarding the risk for depressive symptoms associated with 5-alpha reductase inhibitor treatment. So both finasteride and dutasteride have been associated with risk for sexual side effects, including erectile dysfunction, decreased libido, and ejaculation disorders. So DHT levels have been associated with decreasing levels of nitric oxide and nitric oxide synthase in the corpus cavernosum. So baka yun yung cause. So both doxazosin and finasteride, alpha-adrenergic blocker in a 5-ARI, were significantly more effective than placebo in reducing the risk for clinical progression. Moreover, combination therapy was even more effective than monotherapy. So the risk of acute urinary retention was significantly lower than placebo. And compared with placebo, both finasteride na monotherapy and combination therapy reduced the risk for receiving invasive therapy by 64 and 67% respectively. So next is the muscarinic receptor antagonist, usually used for treating overactive bladder syndromes. Both American and European international guidelines support its use for the treatment of patients with bladder outlet obstruction presenting with predominant and or bothering storage LUTS. The detrusor muscle receives parasympathetic innervation from cholinergic fibers responsible for the stimulation of muscarinic receptors at the peripheral level. So muscarinic receptors, particularly M2 and 3 subtypes, are responsible for involuntary detrusor contractions and are involved in the determination of treatment with muscarinic receptor antagonists or anticholinergics showed significant decrease of the 24-hour micturition frequency and of the nocturnal episodes. So overall, symptoms were noted to be relieved significantly after 1 month of treatment with increases in peak flow rates and post-void residual volumes. So it is important to note, however, that the patients treated with tolterodine as a monotherapy did not report any significant improvement in terms of measures of urgency or significant reduction of IPSS compared with patients who received placebo. So usually sinasama siya with alpha blockers. Next is beta-3 agonist or mirabegron. So the stimulation of the beta-3 adrenergic receptor is responsible for an increase in bladder capacity without a significant change in the micturition pressure, PVR volume, and voiding contraction. So mirabegron acts as a beta-3 adrenergic receptor agonist at the level of the bladder, inducing the trusor smooth muscle relaxation and contributing to urine storage. Showed a significant decrease in the mean number of micturations per day and urgency episodes per day. However, because of previous evidence showing a significant increase of systolic blood pressure among healthy volunteers, mirabegron is not recommended for patients with uncontrolled hypertension. So international clinical guidelines suggest the use of mirabegron as an option for the treatment of patients with moderate to severe LUTS and prevalent storage symptoms. The recommended starting dose is 25 milligrams daily with or without food, which may be further increased to 50 milligrams. So they ruled in on PDE5 inhibitors. They act by reducing inflammation and increasing oxygenation at the level of the prostatic tissue. So medyo marami siyang effects. Relax the prostate and bladder neck smooth muscle. They have an anti-proliferative effect at the level of the prostatic stroma. They can decrease the activity of afferent nerves, thereby decreasing perception of bladder feeling and urgency in the lower urinary tract, and can reduce prostate inflammation. So tadalafil is currently the only officially licensed PDE5 inhibitor for the treatment of male LUTS. So there is a significant decrease of the IPSS and improvement of quality of life, but no significant impact on the urodynamic and uroflowmetry parameters. There is also no significant difference in magnitude of effect among patients with and without erectile dysfunction. So other treatments like phototherapy, they have complex composition and active ingredients. There are variations between plants and extraction techniques of action is unknown. So, but the most studied phytotherapy was saw palmetto or the Serenoa repens. It can inhibit the 5-alpha reductase, both isotypes. And it can inhibit DHT binding to cytosolic adrenergic receptors. And it can inhibit fibroblastic growth factors and epithelial growth factors. It can also inhibit nuclear estrogen receptors in prostatic tissues. And it can modulate prolactin-induced prostatic growth by receptor signal transduction. So yun yung proposed mechanisms niya. However, available data do not suggest that saw palmetto has any clinically meaningful effect. So yun yung recap, yun yung yung non-surgical treatment. Sa surgical therapy, It will be further discussed in detail on Friday, but may overview tayo ngayon. So indications therapy would be a refractory urinary retention, recurrent UTI, hematuria of prostatic origin, bladder stones, renal insufficiency, and large bladder diverticulum associated with UTI and or bladder dysfunction. So marami tayong options for surgical therapy. Pwedeng endoscopic, pwedeng open. Pag surgery, pag nagko-contemplate ka pag surgery, further diagnostics may be required. Like yung Uroflowmetry, PVR, volume, Urodynamics, and possibly cystoscopy, urethrostomy. So transurethral resection of the prostate or TURP is the gold standard. So you usually give systemic antibiotic before surgery, yung usually first generation cephalosporins. Merong non-hemolytic irrigating solutions available. And the height of the irrigant should be 60 cm above the patient. So the mean chance of symptom improvement after cystoscopy TURP is 88%, with a morbidity rate of 15%. Yung complications niya would be bleeding, retrograde ejaculation, and incontinence. So may tinatawag tayong TURP syndrome. It has an incidence of 2%, and yung symptoms niya would be mental confusion, nausea, vomiting, hypertension, bradycardia, and visual disturbance. And is secondary to dilutional hyponatremia, which is causing the symptoms. So usually symptoms would appear when serum sodium concentrations is noted to be less than or equal to 125 milliequivalents per deciliter. So the risk of TUR syndrome is increased if the prostate is more than 45 grams and the resection time is more than 19 minutes. So for the other modalities, meron tayong transurethral needle ablation or TUNA. It uses low-level radiofrequency energy that is delivered by needles, which then produces localized necrotic lesions. So usually, ginagamit yung TUNA kapag may lateral lobe enlargement or kung yung prostate mo is, and if yung prostate mo is less than or equal to 60 grams. So advantages ng TUNA, it can be done under topical anesthesia. It causes precise and reproducible lesions. It is not associated with erectile dysfunction. Disadvantages niya, meron siyang smaller areas of necrosis. 40% of patients have retention within the first 24 hours. And it is not suitable for median lobe enlargement. So, meron din tayong transurethral microwave therapy or TUMT. It uses an antenna that uses microwave energy. So, yung mode of action niya, it causes tissue necrosis due to the heat changes and differential blood flow in the prostate. May damage sa sympathetic nerve endings and meron kang induction of apoptosis. It is less complicated than TURP and can be done as an outpatient procedure. However, it is not as effective. Predicting responders is difficult and there is prolonged catheter time. So may laser din. So light amplification by stimulated emission of radiation. Meron laser ablation and enucleation. So sa ablation, the prostate tissues are burnt away in order to enlarge the urinary channel. And the enucleation, all the obstructive tissues are removed as done in an open prostatectomy. Usually holmium laser yung gamit. According to the American guidelines, it is an effective treatment alternative to TURP and open prostatectomy. There is shorter catheterization time and length of stay, and there are comparable improvements in lower urinary tract symptoms. There's a decreased risk for TURP syndrome, but there is limited information about outcomes due to short follow-up. Next is the transurethral electrovaporization of the prostate. It combines the concepts of vaporization and desiccation. So may steam tissue using high heat and magkakaroon ng dry tissue using low heat. So, gumagamit siya ng electrode. It decreases the risk of TURP syndrome, pero it is not effective for large prostates. There is also a longer operative time versus TURP, and more post-op irritative voiding symptoms, such as dysuria and urinary retention can be observed, and there are higher retreatment rates. Next is TUIP, or the transurethral incision of the prostate. It is limited to smaller prostates, and it is considered for younger patients. There are 1 or 2 cuts made in the prostate, usually sa 5 and 7 o'clock positions. There is reduced risk of retrograde ejaculation, but there is higher retreatment rate. So intraprostatic stents were originally introduced as a definitive treatment, pero hindi laser or TUMT. So next is open prostatectomy. It is indicated when the prostate is more than 75 grams, if there is ankylosis of the hip or other orthopedic conditions that prevent proper positioning for TURP, and when there is recurrent or complex urethral conditions like strictures or previous hypospadia repairs. It's contraindicated for small prostates and prostate CA. So, open prostatectomy may retropubic and suprapubic approach. Sa retropubic, there's enucleation of the adenoma through an incision of the anterior prostatic capsule. While sa suprapubic, meron siyang incision sa lower anterior bladder wall. So, sa laparoscopic or robotic prostatectomy, usually, sabi, there is insufficient published data on which to base a treatment recommendation. Pero ginagawa siya. So, yung advantage ng open prostatectomy is that there are lower retreatment rates, more complete removal of the adenoma under direct vision, and it avoids the risk of TURP syndrome. Pero there is a need for midline incision, longer hospital stay, longer recovery period, and increased chances of hemorrhage. Sa cystoscopy TURP, there is no midline incision and there are shorter hospital stays and recovery periods. Pero yung disadvantage na would be yung TURP syndrome. Between the approaches sa open prostatectomy, yung retropubic approach has an excellent anatomic exposure. It ensures complete adenoma removal. There is precise transection of the urethra, the precise transection of the urethra preserves the continence. And there's visualization of the prostatic fossa after enucleation to control the bleeding. And there's minimal trauma to the bladder. The disadvantage is that there's no access to the bladder, and it's not used for concomitant bladder diverticulum or calculi surgery. And it may be better for large intravesical median lobe surgeries. So sa suprapubic approach, it allows direct visualization of the bladder, neck, and mucosa. It is ideal for large median lobes with intravesical extension. It is ideally for cases with bladder diverticulum or calculi, and is preferred for obese individuals. Ang disadvantage niya is there's reduced visualization of the prostatic apex, and there is more difficult hemostasis. So in an approach to a patient with suspected BPH, one must be worried that presenting male LUTS can have a variety of causes. With proper history PE and corresponding indicative use of ancillaries, one can systemically determine its root cause and address it accordingly. In providing treatment options for the patient, the physician must explain the disease process to the patient and exhaust all means of possible non-invasive therapeutic approaches, only offering invasive or surgical management when indicated.
Okay, so thank you, Dr. Kowa, for that long and detailed presentation. So do we have any questions? So just open your mic, or you can type your questions for Dr. Kowa. So we have a few questions for Dr. Kowa in the chat box. So I think this is for your finasteride. So how frequent do you use your finasteride? How long does the finasteride would take effect? And how, I think the question was how long and how small is the effect to your prostate? So you want to answer that?
So yung in terms of how long, usually 6 to 12 months yung effect niya to maximally take effect. And yung degree of reduction in the prostate volume, I think ang sinabi sa Campbell was 19%, sir. Pero sa isang study lang yun.
Yeah, actually it's around that 20 to 25%. Some would say 30. But I think most of the data would say 20 to 25. But this is Campbell 12 edition, so if it says 9. And the other question, I think this is for the intern. So other name for volume frequency diary. I think the interns answered correctly. Si Turks to eh. Turks, are you there? Call mo na yan. Tama naman yata yung sagot mo. And Dr. Tan corrected me, so up to 30% yung decrease ng prostate. So 20 to 30%. So what else? Do you have more questions? Why is terasin given at nights? Because most of the... you want to answer this? This is due to the side effect. Terasin is given at night due to its symptoms. So if do we have other questions from the panel or interns?
What do you mean binibigay paggabi due to its adverse effect? That's very vague.
Daryl, do you want to answer Dr. Tirol?
Kasi usually, sir, yung side effect, adverse effect ng terazosin would be orthostatic hypotension. So usually binibigay siya sa gabi so that the patients would not experience said hypotension, sir.
So pag sa gabi hindi siya mag-hypotension.
Orthostatic, sir. So hindi siya kailangan tumayo.
So pag gabi walang orthostatic hypotension pag gabi.
Meron, sir, pero hindi mo siya
sabi mo sa gabi bibigay kasi walang orthostatic hypotension.
Sir. Sorry, sir. Hindi mo lang siya ma-experience.
Question ko was bedtime. Pag matutulog na yung pasyente, pagkatapos niyang uminom, hihiga siya, hindi niya mararamdaman yung orthostatic hypotension.
Yes, sir.
At bedtime. You don't instruct him na inumin niya ng gabi. Inumin niya 6 p.m. Matulog siya ng 9.
Do we have more questions, Dr. Tirol? Okay, so for example, in the OPD, and a 55-year-old male came into your clinic due to nocturia of 5 times. So, what questions, based on your algorithm, what questions you may ask the patient? Can the juniors answer or any of the interns? So, 55-year-old male came in due to nocturia more than 5 times. What questions would you want to ask or probe with this patient? Complete ba tayo? Junior. So no one's answering. Daryl, Glenn?
lang, sir. Sir, usually pag nocturia, yung presenting symptom niya, you would ask firstly for any medical conditions like diabetes mellitus or diabetes insipidus. Next, you can ask for urinary symptoms like is it coupled with urgency or frequency? So, pwedeng magkaroon ka ng storage component with your lower urinary tract symptoms. So,
for example, we're leaning on the obstructive side, and we ruled out any medical conditions such as medications, diabetes. What other things that you would do in your physical examination?
Well, I can examine, sir, yung suprapubic region if the bladder is distended. Also, I can do a digital rectal examination, sir, to estimate prostate size.
Okay, so DRE is 4 finger breadths, non-nodular, not hard, not tender. What other laboratory test would you request?
I can ask for urinalysis, sir, since it can detect medical conditions. I can also request for a KUB ultrasound, sir, to determine prostate size. And possibly, sir, I think. Sir?
Would you prefer an abdominal or just a rectal? Sabi mo kasi KUB.
Sir, I think mas magandang rectal. Kasi prostate size yung habol, sir.
No, not really. Not really. But in your line of thinking, what else are you looking for in your ultrasound? More important than the size? You mentioned
presence of nodules, sir.
More. May sinabi ka pa kanina. The nodules, you can detect it by DRE. Can you help him, Ernest? What are we looking for in the ultrasound? You mentioned this before, earlier in the lecture. Naka-mute ka, Ernest.
Postvoid residual, sir.
Ernest. Yo.
Hello, sir.
Naka-mute si Ernest.
Okay na. Didig na namin.
Hello?
Postvoid residual, sir. To check if nag-retain po yung patient. Then, if above 30% po, significant po for L, sir. Yun, postvoid residual, then we can do TUR po.
Ulis.
Wala narinig?
Ayan, nawala yung ano ni ano eh. Pero nawala yung ano mo. Naka-mute ka.
Naputol ako eh. But may sumagot na ba ng PVR?
Yeah, sinagot ni...
Oh, yan. Si Ernest. Sagot ni Ernest.
Elaborate.
Narinig ba ako?
Kanina rin.
Medyo choppy.
Okay, so do you have other tests, additional tests that you would like to request? Sinabi rin ni Daryl sa algorithm niya. Daryl?
Sir, I would request for
Additional
PSA
tests
then,
you can request for this patient.
PSA, sir, determination.
Okay. With the essence of what are you trying to look for?
Possible say screening tools siya din, sir, for malignancy, so I can screen if meron siyang risk for prostate CA. So I can detect.
You cannot detect prostate CA, but it's a screening test for prostate. Okay. So aside from that, you mentioned uroflowmetry and creatinine, right? So you can request for that. So what are you looking for your uroflowmetry? You mentioned din kanina.
Uroflowmetry, you search, you look for the peak urine flow rate, sir.
Okay, good. What number? Magic number?
15, sir.
Okay, good. So and then, would you give your patient medical management?
I think, sir, I can give medical management if yung IPSS ko, sir, is moderate na. I can start the patient with
If
alpha.
Okay. Becomes unresponsive to medication. Then you can offer other modalities for this patient. So do you have other questions from the interns, from the clerks, and from the consultant? See, Dr. Ramanal has a question for Dr. Kowa. So what are the indications for your suprapubic open prostatectomy?
Hindi, Sir Rom, sasagutin ko. Tinatype ko lang. Sagutin ko sana. Anyway, yung ano doon,
Open
i-report
surgery.
ko kasi yun eh. Oo, i-report ko yan eh. Anyway, indications given the approach, suprapubic, will be a large median lobe of the prostate and then a large bladder diverticula or large bladder calculus or calculi. Those will be your indications for a suprapubic open prostatectomy.
Dr. Alpas has a question. So what common maintenance medication can cause
Anticholinergic, sir. Ano ba?
Sir, loop diuretics and beta blockers and anticholinergics, sir.
medyo delay agad tayo sa mic?
Oo, delay yung audio.
And the not satisfied with your answers, guys. Can you elaborate more on the drugs?
The name of the drugs.
Phenylpropanolamine, sir. Mga anticholinergics natin.
Benzodiazepines.
Hello? Am I still here?
Common medications yun. You have to ask these questions whenever you interview a patient.
Phenylpropanolamine, sir. Like
Example.
Decolgen, Neozep, mga yun, sir.
Yun. So, your cold medications.
Yes, sir. Cold medication.
Ayan. What else? Your beta agonist. Example. For the benefit of the interns, para alam nila ano yung watch out for medications. An example?
Salbutamol, sir. Salbutamol, albuterol. Yun, sir. Salbutamol, mga ganun, sir.
Oh, correct. So, yun yung tanongin before you jump into conclusion, may prostate. So, very important, common medications.
Ryan, ano ba yung action ng phenylpropanolamine?
Phenylpropanolamine, sir, is a sympathomimetic na agent, sir, na yun nga, used for decongestant. And usually, ang common na effect niya, sir, is nagkakaroon, sir, ng urinary incontinence sa patient, ng effect, sir.
Is it incontinence?
Parang retention, sir.
Okay, retention. Why?
Kasi, sir, yung effect ng anticholinergic sa bladder wall is to relax the true muscle relaxation, sir.
Yes, but I think the more important they are what? Kung merong alpha blockers, they are what?
Agonist.
alpha agonist.
Alpha.
Okay. So baliktad ang effect niya sa mga alpha blockers, di ba? Kaya lalo kang magre-retain.
Okay, so we have another question here. So ito, easy question. How long must a patient be on 5-ARI for the PSA to decrease by 50%?
Na-mention ni Kowa yan kanina
we all know,
6 months po, sir.
so the other question is, among the surgical treatment that you discussed, what are the treatments that were removed from the recent EA guidelines?
Sorry, sir. Hindi ko nabasa yung guidelines.
Dr. Dan, can I guess this? If I can...
UMT.
Ayan.
TUMT ba? Di ba TUMT?
Ang pinag-isipan ko, TUMT tsaka Urolift.
Oo, Urolift. Wala na rin sa Campbell yung TUMT eh.
Yung Urolift, hindi pa kasi ako yung latest edition this month. Pero hindi ko sure kung Urolift or TUMT. Dr. Dan, is our answers correct?
Hindi pwedeng matanggal yung Urolift kasi hindi pa naman siya part ng recommendations.
Dr. Dan?
Tuna at saka TUMT, if I remember correctly. Tuna and TUMT.
Tuna.
Tuna and TUMT, Rome.
Needle ablation.
Rome.
Okay.
Nandiyan ka ba, Rome?
Yes, sir.
Common sense. Hindi pwedeng matanggal yung Urolift kasi hindi pa naman siya sinasama as recommended treatment for bladder outlet obstruction.
Yes, sir, but according to our guidelines, we have category 1, 2, and 3.
Hindi pa nga siya sinasama sa recommendation. So how can you remove it?
So do we have any more questions? So thank you, Daryl, for that question.
Nice one, Daryl.
Thank you, sir.
Okay, thank you. Kailan ka mag-Euro, Daryl?
Sir, sa June 1, kung tatanggapin niyo ako, sir.
Parang hindi ko pa yata sigurado eh.
Pag na-lift na daw yung ano, sir, pag na-lift na daw yung ano, ECQ.
Pag may vaccine.
Pag nag-GCQ na.
June 1, sir, GCQ ni.
Nga. Kahit dumadami yung kaso ng Metro Manila eh. GCQ na raw.
Okay lang daw, sir.
Oo.
Para daw ma-promote ako, sir.